In this lesson, we're going to be talking about first-degree AV blocks. Now, first-degree AV blocks are actually more of an interruption. They're not a true block in the sense of the electrical stimulus is being blocked from moving forward, but the PR interval is affected. So we're going to take a look and see what's happening here between the AV node down to those Purkinje fibers. If you recall that when the SA node is sending its electrical charge to the AV node, there's nothing wrong with the system above the AV node. So we will still see a nice round P wave on our ECG tracing. But what's happening here is that the AV node is holding on to the energy just a little longer. Now imagine, if you will, an analogy here is when you go to work, you have your same route. You know exactly how long it's going to take you to get to work every day. Well, now they need to fix the sidewalk and there is a construction zone. And every morning you are delayed 5 minutes more than usual. And this becomes your new normal. The same thing is happening with the AV node. This is the least troublesome of all the AV node blocks. However, it can turn into a more serious arrhythmia, so we do need to pay attention. Now, just like our previous blocks, this may be a temporary situation, as it could be related to medication admin. If you recall, calcium channel blockers, beta blockers, digoxin, or it can be more permanent. So when we look at our ECG rhythm strip, what we notice here is after the P wave, there is a longer span before the QRS complex fires. And it is that longer span that's indicating that the PR interval has widened and the AV node is holding on to electricity. Now recall that isoelectric line, this flat line here, that is time when there is no electrical movement in the heart. And so we have our SA node firing, traveling down through the atrial tissue, gets to the AV node and wait and wait and wait, and then it releases. Now the consistent pattern here is that you will see the same delay at every contraction. Much like you have that same 5-minute addition to your travel because of the construction on the sidewalk. When we compare this to normal sinus rhythm, we can start to see that prolongation of the PR interval. And so what we're going to see on our rhythm strip analysis is that the PR interval is actually outside of the normal range. So to help you remember this, we have a saying. It says, if the R is far from the P, then you have a first degree. When auscultating heart sounds, you will not notice a difference. You'll still hear an S1 and an S2. So when looking at the parameters of our waveforms and intervals, we can see here that everything is normal with the exception of the PR interval, and this is its characteristic feature. So the rhythm of the atrial and the ventricular will be regular. The rate will be between 60 and 100. Our P wave will be round and upright. Remember, the SA node is not the problem here. It's the AV node that's hoarding that energy. There will be a 1-to-1 conduction, so there's still one P wave for every QRS wave. But the PR interval is greater than 0.20 seconds consistently across the board. QRS complex is still between 0.06 and 0.12 seconds, and the QT interval 0.36 to 0.44 seconds. ST segment will be flat. Now the first degree block represents a predictable and regular delay of electrical signals through that AV node. And although the conduction is slowed, there are no missing beats, as every impulse from the atria is conducted down through the ventricles. As I mentioned, it is the least dangerous type of the 4 AV blocks that we're going to talk about today. Again, as noted, we can't just disregard this rhythm as inconsequential. A first degree AV block, while it may be the least troublesome, can progress into a more serious form of block, so monitoring the patient is important. Now, I know we talked about the common causes for all the AV blocks, and in particular medications, beta blockers, calcium channel blockers, rate blockers, ischemia, so that decreased oxygen being an early warning sign of a cardiac event, and degenerative changes in the heart. If we can detect this early, we can reverse the arrhythmia and return it back to normal sinus rhythm. So let's talk a little bit more about calcium channel blockers here. I've got 3 here listed on your slide for very good reasons. They work on different sites, or they have an affinity for different sites of the heart. And it's important to recognize that not all calcium channel blockers are equal. So diltiazem is a benzothiazepine calcium channel blocker. This one focuses on slowing down the SA and AV node conduction, often used for atrial fibrillation, atrial flutter, and it can be used alone or in combination with other drugs such as ACE inhibitors. So this will affect both vascular smooth muscle and cardiac muscle. Verapamil is often used to treat hypertension, chest pain, that ischemic chest pain that happens, and it is functioning, or its role is to decrease the movement of calcium inside the cardiac cells. So it's going to decrease our blood pressure and slow AV conduction by inhibiting the movement of calcium. Dihydropyridines, an example would be nifedipine, if you've used that one in clinical practice. This one has more of an affinity for the peripheral vasculature, and it will cause peripheral and coronary vasodilation. So this is really focused on reducing that peripheral vascular resistance that the heart is pushing against and afterload. This will result in a lower blood pressure. So we obviously would not want to give a calcium channel blocker to a patient who is dependent on that preload, or who that's the blood coming back. So I don't want to vasodilate them because they're not going to have a good ejection fraction. The point here is, though, knowing that calcium channel blockers, because they're actually impacting the movement of electrical stimulus from SA node to AV node and that movement of calcium, is that may be the reason your patient is in a heart block. Now, those who have a first-degree heart block are mostly asymptomatic. It's just a slight delay. They don't realize it's happening until they come in for some other investigation, and it is often a coincidental finding. Treatment is just to educate them and to adjust medications if they need to be adjusted. So if they are on a calcium channel blocker or a beta blocker or digoxin, we'll be doing some lab values to see if they're at a therapeutic level and adjusting doses accordingly. Of course, we want to investigate other causes because medications are not the only reason, as discussed in a previous module. So we'll be looking again for electrolytes, glucose, autoimmune disorders. Maybe they are on antibiotics, and so that's causing some changes. Symptomatic patients need to be paced because we want to ensure we're maintaining cardiac output for those vital functions. Now I want to talk to you about Mr. and Mrs. Jones. We're going to use this couple throughout all of the AV blocks to demonstrate and to give you an analogy of this in real life. So the P wave represents the wife, and the QRS represents the husband. Now you can change this around. It doesn't matter to me who you use in your analogy, but the concept is what I want you to understand. And here we have the P wave, lovely Mrs. Jones, waiting at home for her husband. Now in normal sinus rhythm, this is a very well-functioning couple and very successful because they have really good communication. One washes the dishes, the other dries, one buys the groceries, the other cooks. They've got a system worked out. And whoever gets home early, we're going to say it's the wife, she knows the husband is coming right behind her, and it won't be long and he'll be home. Like clockwork every day. That would be a normal sinus rhythm. In a first-degree block, when the wife gets home, she notices that the husband is delayed, and he gets home just a little bit later every night, but at the same time every night. So let's just say he used to come home at 6 p.m. Now he's coming home at 7 p.m. Every night he's that consistent 1 hour delayed, and she can count on that. She knows he's going to be home. It's just going to be a little late. In our next section, we're going to move into second-degree AV blocks.